Okay, just give me a confirmation if I'm audible now. Am I audible now? Once you give me a confirmation, we will get going from there. Am I audible now, guys? Okay, cool. So we'll start with the basics of ECG today. We are going to run it as a series. This will run for around 12 to 16 sessions, and we will start from the very basics because ECG seems very difficult only because we try to learn everything about ECG in a very short span of time. ECG has a lot of concepts, mathematical equations inbuilt into it. So you have to always take it as one concept at a time and then build it from one concept to the next concept once we are thorough with the previous concept. Only that way we will be able to master the ECG. If you say that, sir, there is someone who can teach ECG in half an hour, 1 hour, well, it's going to mess up mostly, or you can be like exam ready but not truly master the ECG. So today we are beginning with the basics. Okay, so what are we going to cover? Well, we will start with the conduction system of the heart. We all know that heart is a muscular organ. It contracts and ejects the blood, right? Left ventricle ejects into the aorta, right ventricle ejects into pulmonary artery. And for that contraction, heart is not completely automatic. At the same time, it is not under voluntary control, right? I can't stop my heart voluntarily. But at the same time, a muscle cannot contract on its own. Right now, I'm talking to you. Will my biceps start contracting on its own? No. For me to contract my biceps, I have to send an electrical impulse from my motor cortex of the brain all the way down through the pyramidal tract. Then lower motor neuron has to take that electrical impulse and deliver it to muscle. Then the muscle will contract. So muscle can only contract once there is a stimulus. So for these chambers also to contract, I need a stimulus. But of course, my brain is not generating that stimulus. So I have to create a nervous system inside the heart which can generate the stimulus for the heart to contract. That stimulus generating system is what we are going to call it as the conduction system of the heart. Okay. Now, the conduction system of the heart starts with a small tissue in the right atrium which we call as the SA node. This is considered as the pacemaker of the heart, right? Why are we calling it as pacemaker of the heart? Because the electrical impulse required for the contraction of whole of the heart starts from this tissue, right? Now what this tissue does, this tissue sends that electrical impulse to another structure which is called as AV node, Now how this AV node is going to receive the electrical impulse? Remember, AV node receives the electrical impulse through 3 tracts which we call them as internodal tracts. We are calling them as internodal tract. You may say, sir, whatever electrical impulse that SA node generates, right? Why doesn't it just travel directly across the atria and reach the AV node? Well, that is possible. But we want to deliver this impulse to the AV node as quick as possible. So we need specialized conducting tissue. That specialized conducting tissues, we are going to call them as internodal tracts. Internodal tracts. Why are we calling them as internodal tracts? Because these tracts are between these 2 nodes, SA node and AV node. Okay. Now, once the SA node starts an electrical impulse, it will spread across the atria and cause atrial contraction, right? It will cause atrial contraction. Now, which chamber will get contracted first? Is it the right atrium or the left atrium? Is it the right atrium or the left atrium? Which chamber is going to contract first? Or both the chambers are going to contract simultaneously? So if you're thinking that both the chambers are going to contract simultaneously, we are partially wrong. Why? Think about it. SA node is there in the right atrium. Don't you think there is some amount of time required for this electrical impulse generated by SA node to reach the left atrium? It will reach the right atrium much faster, right? It will take some time to reach the left atrium. So there is always a fraction time gap between the right atrial contraction and left atrial contraction. But still, nature has designed a mechanism which can quickly transform this electrical impulse from the SA node to the AV node. So there is a connecting pathway between the right atrium and left atrium. So what are we going to call it as? Either we can call it as interatrial tract, or better, we will name it with the name of the scientist who discovered it. It is called as Bachmann's bundle. It's called as Bachmann's bundle. So Bachmann's bundle is the one that connects SA node to the left atrium, so that the time taken for the electrical impulse generated by SA node to reach left atrium is minimized. So we have somewhat simultaneous, though right atrium is slightly ahead of left atrial contraction. Okay. Now once the electrical impulse travels across the atria and causes its contraction, now the electrical impulse has to reach the ventricle to cause the ventricular contraction. So during atrial contraction, whatever blood I have transferred to the ventricles, right? Now ventricles have to contract to eject this blood to their respective arteries. So this electrical impulse has to reach the ventricle. Okay. Now the question is, can the electrical impulse pass directly from atria to ventricle? Can it pass directly from atria to ventricle? What do you think? Can the electrical impulse generated by SA node can directly go to atria to ventricle? The answer is no. Why? I'll tell you. First of all, whatever these tracts, internodal pathways, and the Bachmann's bundle we spoke about, they all contain cells which have gap junctions. And because of that, the electrical impulse travels faster through them. But between atria and ventricle, we have a thin sheet of tissue. There is a thin sheet of tissue which contains tight junctions. So electrical impulse from atria can never directly go to the ventricles. It can never directly go to ventricles until and unless there is a pathology, right? Until and unless there is a pathology. So what are we learning now? If I send an electrical impulse to atria, it can only cause the depolarization of the atria. Atria is separated from the ventricle by a tissue layer which contains tight junctions. So electrical impulse from atria cannot leak into the ventricle. Look at the beautiful design of the nature, because if atria gets depolarized quickly, it will contract, and if the impulse is immediately transferred to ventricle, that will also contract. So what is the result? Atria is contracting, ventricle is also contracting. So both the chambers are contracting against each other. So I will not be able to transfer the blood from atria to ventricle. So when atria contracts, ventricle should be in a relaxed state. Only then I will be able to transfer this blood. So first atria should contract and then ventricle, but electricity travels quite fast, right? So if I send an impulse, it will cause atrial contraction, immediately reach ventricle, and cause ventricular contraction also. So we had to break that. How nature breaks it? By creating a layer of tissue comprising of the tight junction so that electrical impulse cannot leak. So there is only one window of opportunity for the electrical impulse to reach the ventricle from atria, and that is our AV node. And AV node is designed in a way that it does a 0.15 second delay. Means once SA node sends an electrical impulse, it will reach the AV node, but AV node will not transfer it to ventricles immediately. It holds for a very tiny fraction of a second, 0.15 seconds. So when it holds, the ventricle will be in a relaxed state. It receives the blood. Once ventricle has received the blood, then AV node will pass the impulse down, so that now the ventricle can contract and eject. Okay, clear? So what is the function of AV node? Its function is to receive the impulse from the SA node and then do the delay which is required for sustenance of life, and then transfer it to the ventricles. Now how do I transfer it to the ventricles? So to transfer it to the ventricles, I need another pathway which we will call it as His bundle. So there is His bundle which receives the impulse from the AV node, and then this His bundle splits into two. So we'll call it as bundle branches. The one on the left will be called as left bundle branch, and the one on the right will be called as right bundle branch. And these bundle branches will now enter into the ventricles, and then they will continue as what we call as Purkinje fibers, and the Purkinje fibers percolate into the ventricular musculature, and they will deliver the electrical impulse for the ventricles to get depolarized, and thus the ventricles will be able to contract. So the story starts in the SA node. It initiates an electrical impulse which will travel through the atria to cause its contraction. It will also reach the left atrium through Bachmann's bundle to cause its contraction, and the wave also reaches the AV node through internodal pathway. AV node does the necessary delay and then transfers it to His bundle. His bundle splits into right and left bundle branches. They will end in Purkinje fibers. Purkinje fibers deliver the electrical impulse to ventricle, and ventricles contract. Okay, so this is the organization. Now we are calling SA node as a pacemaker because it is initiating the electrical impulse. But for some reason, if there is someone who is born with an SA nodal dysfunction, this is not properly functioning, does it mean the individual will die and he cannot sustain life? The answer is no, right? In this hierarchy, SA node, AV node, His bundle branches, and Purkinje fibers, all of them are capable of initiating automatic electrical impulses. Means they can also be pacemakers, but they are supplementary or accessory pacemakers. In the sense, if SA node doesn't send an impulse, then AV node can become a pacemaker of its own. If AV node is not able to pass down the impulse to his bundle can become the pacemaker of its own. If his bundle is not able to bring the impulse down, then bundle branches can become their pacemakers. Even Purkinje fibers can become pacemakers. So does that mean that I don't really need SA node and my life is going to be great without the SA node? The answer is no. Why? Because SA node, the rate at which it can keep firing the electrical impulses, right, is much higher. And as I go down in the hierarchy, I jump from SA node to AV node, the rate of initiating the electrical impulse drops. So if I go further down, the rate of initiating the electrical impulse drops. So as I go down and down, the rate at which my heart can contract goes on decreasing, or in other words, the heart rate goes on decreasing. So the best thing for me is to have the SA node as the pacemaker. If not, I may be able to survive with AV node as a pacemaker, but my heart rate will be low. But if I have low heart rate, what problem it can lead to? Why it is not acceptable to have low heart rate? Why it is not acceptable to have low heart rate? We all have studied that there is a formula for cardiac output, which is stroke volume into heart rate, right? So if the force of contraction of my ventricles is constant, and if my heart rate decreases, what will happen to my cardiac output? The cardiac output decreases. So I will not be able to perfuse my tissues well, right? I will not be able to tolerate physical efforts well, because during that time, the demand of cardiac output by tissues increases, right? So that's why we need to have SA node as the pacemaker. Clear? Okay. So the next thing that we need to study before we go forward is the rate at which these structures are able to function as pacemakers. So SA node, when it is the pacemaker, it generates electrical impulse in the rate of 60 to 100 per minute. So that's why we say normal heart rate is 60 to 100, because SA node keeps firing at a rate of 60 to 100. This is my physiological range. Can this increase or decrease? Yes, SA node is not totally automatic. It is under the control of autonomic nervous system. So if I activate sympathetic nervous system, like I get scared, right? Or I just notice that there is a snake around this place, so I have to run, right? My sympathetic nervous system gets activated. Sympathetic nervous system stimulates the SA node. So then SA node's rate increases. If I'm starting at 60, I can go to 100 or even beyond that. This is the normal resting rate that we're talking about, 60 to 100. Similarly, if I go in a deep meditative state, then parasympathetic nervous system will get activated. That suppresses the SA nodal activity. My heart rate can even drop below 60, right? But otherwise, in a resting state, our heart rate is 60 to 100 because SA node is our pacemaker. But if SA node is dysfunctional, right, can atrial myocardium act as a pacemaker? Remember, the myocardium, whether it is atrial or ventricular, cannot fully act as a pacemaker. They cannot generate their own electrical impulses under physiological conditions. In pathological conditions, they can be a reason for arrhythmia, but not in physiological state. So atrial myocardium cannot generate any electrical impulse. It can't act as a pacemaker. But if I go to AV node, the rate is somewhere between 40 to 55. So if SA node goes into dysfunction, my heart rate will drop down to a range of 40 to 55. If AV node is also dysfunctional and my bundle of His is becoming the pacemaker, then my heart rate drops down to 25 to 40, because this is the rate at which bundle of His can fire continuously as the pacemaker. Bundle branches also carry the same rate, and Purkinje fibers also roughly carry the same rate. And ventricular myocardium, it cannot generate a pacing. So myocardium per se cannot generate pacing, but rest of the structures can. Okay, clear? Now just to give you an example, right, how understanding this helps us to understand ECG better. Now think about it. I have an individual where AV node is damaged. AV node is damaged. Okay. SA node is functional, his bundle is functional. Only structure that is damaged is the AV node, right? AV node is dysfunctional. In that case, in my heart, who will be the pacemaker for atria? SA node is functional, right? So SA node will send the electrical impulse for the atrial depolarization. So what will be my atrial rate in that case? Atrial rate will be 60 to 100 because the pacemaker for my atria is SA node. But AV node is damaged, it is not able to conduct this impulse down to the ventricle. Now what will happen? Because AV node is not passing the impulse down, either his bundle or bundle branches or Purkinje fibers, one of them will become the pacemaker. Most likely in this case, it will be his bundle, right? His bundle becomes the pacemaker for the ventricle. So in that case, what will be the rate of the ventricular contraction? Ventricular contraction rate will in that case become, what is the pacing rate of his bundle? Pacing rate of his bundle is 25 to 40. So my ventricular rate will become 25 to 40. So now look at this. Atrial rate, atria is contracting at much higher rate, ventricle is contracting at much lower rate. This is what we call as AV dissociation, atrioventricular dissociation. In normal circumstance, what happens? Atrial rate is equal to ventricular rate because SA node is the pacemaker, AV node is functional. So one atrial contraction will lead to one ventricular contraction with a delay in between. So when atria contracts, it is able to push the blood to ventricle. When ventricle contracts, it is able to eject the blood to the respective artery. But if I create a separate rate, right, atria is contracting much faster, ventricle is contracting much slower. So sometimes the atria will be contracting simultaneously with the ventricle. Sometimes it will be contracting before the ventricle. Sometimes it will be contracting after the ventricles because the rates of the two chambers are now different. This is what we call as AV dissociation. Why this happened? Because AV node got completely blocked. This is what we call as complete heart block. Now, why is this a big problem? Because ultimately the cardiac output does not depend on the atrial rate. It depends on the ventricular rate. So if ventricular rate has dropped down to 25 to 40, my cardiac output by default will significantly come down because cardiac output is equal to stroke volume into heart rate. So complete heart block patients often have hypotension. Why do they have hypotension? Because ventricular rate is very low, heart rate is very low, so the cardiac output will be very low. And we should remember that the systolic BP is directly proportionate to cardiac output. Lower the cardiac output, I will have lower systolic BP. Clear? Okay, so now what we have understood? We have understood the pacing mechanism and the rate of automaticity or rate at which these structures cause pacing. And another thing that we have understood is the atria and ventricles are separated by tissue which contains tight junctions, and thus atrial electrical impulse are impermeable and they cannot reach to the ventricles. The only window through which impulse coming from the atria can enter into the ventricle is AV node, and AV node is designed in a way that it causes the AV nodal delay. Okay, so with this backdrop, now let us look at the ECG waveforms. So when SA node sends an electrical impulse, it will cause depolarization of the atria, right? Right atrium slightly ahead of the left, and this atrial depolarization produces a waveform which we are going to call it as P wave. So P wave is, as we know, is due to atrial depolarization. It is a wave of atrial depolarization. Now, if I have to look at any of the abnormalities of the atria, like let us say the right atrium is enlarged or left atrium is enlarged, which waveform I should be looking for? The wave of atrial depolarization is P wave, right? So if atria is enlarged in size, I have to look at the P wave. Similarly, whether atria is contracting or not, I want to see which wave I should be looking for. P wave, right? If atria doesn't get depolarized, it doesn't contract. So in that case, what will happen? The P wave will be absent. If I'm able to see a P wave, that means atria is getting depolarized and thus it is getting contracted. Okay. Now, once this impulse through the internodal fibers reaches the AV node, AV node will cause the necessary delay. It is not going to transfer this electrical impulse immediately to the ventricles. So this wave will not lead to the ventricular depolarization immediately because there is AV nodal delay. So the electrical axis will remain on the baseline, right? So this is what we call as baseline or the isoelectric line, and this portion is suggestive of AV nodal delay. AV nodal delay. Okay. Then after the AV nodal delay, the impulse will now travel through the His bundle branches and Purkinje fibers and cause the ventricular depolarization. The ventricular depolarization produces a complex wave system which includes Q, R and S, right? Q, R and S. So QRS represents what? QRS represents ventricular depolarization, right? This is representing ventricular depolarization. Ventricular depolarization. So if I have to recognize any abnormality of the ventricles, like for example, there is left ventricular hypertrophy or there is right ventricular hypertrophy, which waveform I should be looking at? I should be looking at the QRS complexes. Let us say ventricle is not contracting. Which waveform I should be looking for? Whether ventricle is contracting or not? Again, the QRS complex. Because QRS complexes tell me about the ventricles. The P wave tell me about the atria, right? Now, once the ventricle gets depolarized, right? Any chamber which gets depolarized, for it to get depolarized again, before that it has to get repolarized. So atria that got depolarized, it gets repolarized, but the atrial wave of repolarization is buried somewhere inside the QRS. In a standard ECG, we can't see it. But ventricular depolarization wave, I can see it. That is in the form of T wave. So T wave is the wave of ventricular repolarization. It is a wave of ventricular repolarization. Repolarization. Okay. Between this QRS complex and ventricular repolarization. QRS is ventricular depolarization and T wave is ventricular repolarization. Before that, there is a time gap, right? Ventricle gets depolarized, stays in a depolarized state, reaches the isoelectric line, and then again gets repolarized. So this time gap is what is ST segment, and what is it representing? It is representing the isoelectric line between ventricular depolarization and repolarization, right? So this is the isoelectric line between ventricular depolarization and repolarization. Okay, now I have a question. The question is, if I have to look at the ECG and identify a PR segment, you should tell me which one you will count it as PR segment, right? Let me say I'm drawing two lines. One is in yellow color, if you are able to see. Okay, and the other, let me draw in blue color. So which one of them is a PR segment? We know P, you know Q, R, S, T, U, T waves now. Which one of them is PR segment? Is the segment between blue lines or is the segment between yellow lines? Which one is PR segment? What do you think? Because now that we know the basics, it's time for us to understand the segments, intervals, and other concepts. This is an yellow line. This is an yellow line. Okay. So is this the PR segment or is this the PR segment? Which one is? Of course, right. That is between blue lines we have segment and between yellow lines we have interval, right? We'll try to understand that. Before that, I missed one waveform. In some ECGs, you may see another wave called as U wave, right? This U wave is due to repolarization of Purkinje fibers. Repolarization of Purkinje fibers. So Purkinje fibers take some time to repolarize. So in some ECGs, not always, you may be able to see a U wave. It can be seen in pathological conditions, which we will discuss in the subsequent sessions. In a physiological condition, if you are able to see a U wave, it is because of repolarization of Purkinje fibers. Okay. So then what is this interval and concept? Interval and segment. Remember, in the ECG, there are three lines which are on the baseline, isoelectric lines. What are those? Between P and QRS, which is representing AV nodal delay, right? And then between S and T. And then from the T, forget about the U wave, not usually seen, from the T to the next P wave, right? From T to the next P wave. These are the three isoelectric lines. These are called as segments. Okay. So what are we learning here? Segments do not contain any wave, right? Whenever you say segment, it is devoid of any wave, right? Do I have any wave here in between these two lines? No. So then it is a segment. Do I have any wave between these two lines? No. So then it is a segment. But when I draw lines here, within this there is a wave. So whenever between two intervals, if there is a wave involved, we will call it as interval, right? So first thing we learn is segments represent isoelectric line. Segments represent isoelectric lines and they do not contain a wave. They do not contain a wave. So it is a point in the cardiac cycle where the electrical activity of the tissues is net at the baseline, or you can say net zero in comparison to the other waveforms which are either positive or negative. It is the baseline. What can go wrong with the segments, right? Either the polarity or there can be depolarization of this segment also, then it will get elevated. So segments can be elevated. Like in case of MI, we have ST segment elevation, right? Or in the non-ST elevation MI, there can be ST segment depression. So we never talk about the segments being prolonged. We only talk about segment being elevated or depressed. So if this ST segment instead of here goes all the way here, then it is ST segment elevation, right? Or instead of it, it goes like this, then there is ST segment depression. So how many segments are there in the ECG? There are three segments. The first one is PR segment. PR segment begins at the end of P wave and ends with the beginning of QRS. Ends with the beginning of QRS. Now you may get confused. Sir, here it is talking about R, but you are saying it ends with the Q. Remember, in all leads, Q wave is not easily visible. So when we say PR, we are primarily referring to the QRS complex, not just R as a wave. So it ends with the end of the PR, it ends with the beginning of the QRS complex. So PR segment is between, or you can say begins with end of P and ends with beginning of QRS. This segment can be elevated or depressed. It gets depressed typically in patients with acute pericarditis. Right now, you don't have to worry about it. We'll just understand the basics. The second segment that we have is ST segment. ST segment. So this is also a baseline, right? This also does not contain any wave. So where does it begin? It begins with the end of S wave and ends with the beginning of T wave. This is my ST segment. And the point at which the S wave terminates, this point we call it as J point. J point. The point at which the S wave ends and the baseline begins. This point is called as J point. So you can also say that the ST segment begins with J point and ends with the beginning of the T wave. So ST segment begins with end of S wave, or you can also say end of the QRS complex, and that point is called as J point, and ends with beginning of T wave, ends with beginning of T wave. This is the most important segment in an ECG because the diagnosis of myocardial infarction, STEMI, and even the non-ST elevation MI is like we are primarily focusing on the ST segment, right? When we understand ST segment better, we can save lives, right? We can act quickly and we can save lives. Then we have one more segment which is called as TP segment. TP segment. So this segment begins with the end of T wave, begins with end of T and ends with the beginning of next P. ends with beginning of next P. Now this TP segment also gets altered in acute pericarditis, which we will learn later. So just to give you a quick heads up on what we have discussed so far, let us say this is one waveform I am looking at. So we will label the segments. So this segment is going to be PR segment, right? This PR segment. And then this segment is the ST segment. And then this segment is the TP segment. So we have 3 segments. Now after the segments, it's time to learn about the intervals, right? How many segments are there in the ECG? 3. PR, ST and TP. PR, ST and TP. Segments can get elevated or depressed. In standard ECG, we generally don't talk about segments being prolonged or shortened. Okay. Then we have intervals. So I was showing you one line beginning with the beginning of P wave and the end of the beginning of the QRS complex. So this is our PR interval, right? Similarly, from the beginning of the Q to the end of S, it is QRS interval. Intervals always contain a wave. And one more, beginning of the QRS to the end of T wave. This is Q say T. So we'll call it as QT interval. QT interval. Very, very important concepts. Segments, mainly ST segment, rest of the things are not important, but intervals are very, very important. So first we will start with the PR interval. PR interval. Remember, the thumb rule to remember is intervals always contain a wave. Intervals always contain a wave. Segments do not contain a wave. Segments are divide of wave. Intervals always contain a wave. So what is this PR interval? So PR interval begins with the beginning of the P wave and ends with the beginning of QRS complexes. Right? It begins with the beginning of P wave and ends with the beginning of QRS. So this is the PR interval. PR interval. From beginning of P to beginning of QRS. Now what does this indicate? What does this indicate? Rohina, Rashid, absolutely. Absolutely. So PR interval will help us to diagnose the AV blocks or heart blocks. What does this indicate? What is the P wave representing? It is the wave of atrial depolarization, right? And what the PR segment is representing? AV nodal delay. So can I say that the PR interval represents the time taken by the impulse initiated by the SA node, right, to cause the depolarization of the atria and then reach the AV node, have the delay and then get transferred to ventricle. Means from beginning of the impulse in the SA node to the beginning of the ventricular depolarization, because ventricular depolarization wave is QRS, right? P is atrial depolarization. In between that there is a AV nodal delay. So PR interval talks about the time taken for atrial depolarization plus AV nodal delay, right? So if any condition where the AV nodal delay increases, what will happen to the PR interval? So PR interval is representing time taken for atrial depolarization, which is our P wave. Depolarization, which is our P wave, plus AV nodal delay, which is our PR segment. Together we call it as PR interval. So if the time taken for the atria to get depolarized increases, what will happen to the PR segment? It becomes prolonged, the PR interval, sorry. Or if the AV nodal delay increases, what will happen to the PR interval? It becomes prolonged, right? So when we were talking about the conduction system of the heart, I told you that the impulse cannot enter the ventricle directly from atria, only window is AV node. But if someone is born with a breach in this insular tissue or the tight junction tissue, then electrical impulse can enter the ventricle directly, right? They are bypassing the AV node, so there is no delay. They are reaching the ventricle quickly. So in that case, what will happen to the PR interval? AV nodal delay is not there. So P wave immediately the QRS. So the total PR interval becomes shortened, like you see in patients with WPW syndrome, where they have an accessory pathway which connects the atria and ventricle bypassing the AV node, right? That is what we call as short PR interval. Okay, so today again, no need to bother about all these short, long. All I want you to remember is that intervals contain a wave. One of that interval is PR interval. PR interval starts with the P wave, beginning of the P wave, and ends with the beginning of QRS. So within this, it has P wave and PR segment. P is atrial depolarization, PR segment is the AV nodal delay. Together that is PR interval. Okay, now what is the next interval we talk about? The next interval we are going to talk about is going to be QRS interval. The second interval is QRS interval. Now what is the QRS waveform representing? This is P, Q, R, S, and then I have T. So when I say QRS interval, I am referring to beginning of Q wave to the end of S wave, right? To the end of S wave. So this is what we are going to call it as the QRS interval. QRS interval. Interval always contain wave. So here also we have Q wave, R wave, and S wave, right? So it begins with beginning of Q to end of S. And what does it represent? This is representing the time taken for ventricular depolarization, right? It is equal to time taken for ventricular depolarization. So if ventricles take more time to get depolarized, what will happen to this QRS interval? It will become prolonged. If ventricles are taking less time to get depolarized, the QRS interval becomes shortened, right? So that is the second interval, QRS interval. We have one more, the third interval, which we will call it as QT interval. QT interval. So what is this QT interval? Again, as I've already told you, intervals always contain a wave. So we are saying it starts with Q and then ends with the end of T. Then we will call it as QT interval, beginning with the Q and end with T. So let us say that this is my Q, this is R, S, and T. So this whole interval is QT interval. So this is from the beginning of Q to end of T wave. That is my QT interval. Now in terms of concept, what does that represent? QRS is ventricular depolarization. T is ventricular repolarization. So QT interval tells me how much time it takes for ventricle to get depolarized once and then get repolarized back, right? So time taken for one cycle of ventricular depolarization followed by repolarization. So time taken for ventricular depolarization, then the gap between the depolarization and repolarization, that is ST segment. So this is QRS plus the isoelectric time, that is ST segment, plus I have the ventricular repolarization. Which is my T wave. So now QT interval is again a very important interval, because lot of conditions where there is QT interval prolongation, mainly right now caused by drugs. Some people can also be born with long QT syndrome, congenital long QT syndromes. These people are at increased risk of developing ventricular tachycardia and ventricular fibrillation, which we will discuss in the later part of the sessions. But for now, we have understood that in the ECG, we have P wave of atrial depolarization, PR segment because of AV nodal delay, QRS complex because of ventricular depolarization. ST segment is the isoelectric line where ventricle is depolarized and it is not repolarized, right? That is the baseline. And then we have ventricular repolarization in the form of T wave. Then we have three segments: PR segment, ST segment, and TP segment. Segments do not contain any wave. They are actually representing the baseline or isoelectric line where there is no major electrical activity happening in the heart. And then we have the intervals. Three most important intervals are the PR interval, which represents the time taken for atrial depolarization plus the AV nodal delay. In other words, you can say the impulse generated by SA node, time taken for it to reach the ventricles. Okay. Then we have the QT interval and we have the QRS interval. QRS interval just tells us about the time taken for ventricular depolarization, and QT interval tells us about the time taken for ventricular depolarization and then the gap and then the repolarization. Okay. Abnormalities we will discuss later. Okay, now this QT interval is one thing which is influenced by heart rate, because if heart rate goes on increasing, right, then the ECG waveform should become shorter, because in a short span of time I have to have multiple contractions. So what gets shortened? It is the QT interval. So QT interval has to be always corrected for the heart rate. So there is a formula for it. That also we'll discuss when we take up these individual waves. Right now we're not discussing any of the abnormalities. We are only trying to understand the basics. Okay. So now that we have the basic understanding which waveform represents what and what are the segments and intervals, let us acquaint ourselves with the ECG paper, because paper holds the key, right? Not our understanding of PQRS, but paper, because whatever it is documented on the paper. So when we look at the ECG paper has two axes, right? One, let us call it as Y axis, another X axis, right? This is X and this is Y axis. So now P wave, as we know, right? Let us say this is one P wave. What is it representing? Atrial depolarization. Okay. Now to cause atria to depolarize, I need to generate some degree of electrical impulse, right? That is expressed in terms of voltage, right? I have to plot that voltage, because see, this P wave is not as the same size of the R wave. Why they are of different sizes? Because when ventricle gets depolarized, the electrical impulse generated there or required to cause the ventricular contraction will be higher. So the voltage required will be higher. For atrial depolarization, voltage required will be lower. So I have to document that voltage of an event on the ECG. Second, atria takes some time to get depolarized, right? Like just look at this image. Once SA node sends an impulse, it will spread through the atria and cause its depolarization. So it is not instantaneous. It takes some time. So this time taken for the atrial depolarization, right, that also has to be documented on the ECG. So what we do on the ECG, on the X-axis, we are plotting the time. X-axis plots the time. So if I have to read the time taken for any event on the ECG, right, I have to read it horizontally. Like if I say that QRS interval I have to measure, time taken for the ventricular depolarization, then I have to read it horizontally. Okay. And in the Y-axis, I'm plotting the voltage of that particular waveform, or you can call it as amplitude, right? We will call it as amplitude or voltage. Amplitude or voltage. Okay. Now I have one very important question. Very important question. Rohina says very good. Okay. When we have an ECG machine, what drives? There is a needle on the ECG machine which is drawing all these waveforms, right? What is the principal driver for it? Is the electricity generated by heart is supplying the energy for the needle to make the waveform, or we need an external electric supply, right? Can the electricity generated by heart sufficient to move the needle? No, right? Because our ECG machines won't work unless they are plugged or they have the battery reserve. So basically it is the electrical impulse that is generated by the heart is sensed by the ECG, and then the power supply, right, that delivers the energy required for the needle to make a waveform on the ECG. That is the conventional current modern ECG machines. So now, can I have the flexibility to to set, like if let us say there is one event which is taking one, which has a voltage of 1 millivolt. Now how much line it should draw on the paper? Who sets it? Is it me, the nature, or something else? 1 millivolt, whether I should draw this big line, or for 1 millivolt I should draw this big line. How will I decide? Who decides it? Okay, so remember, when we, like, you go to an architect and ask him to make a plan for your house, right? So he makes a plan, right? He makes a plan like this is how your house will be there, and then he mentions the scale, right? So like he will mention saying that 1 centimeter height is equal to 2 meters. That is the scale, right? We have all done this in our +1, +2. So similarly, there is a scale in the ECG. We can set 1 millivolt should reflect as how much big line on the ECG. Okay. So now how will I get to know in a given ECG how much big line 1 millivolt makes? So remember, in every ECG, you get something like this in the either on the right hand side or on the left hand side. This is what your physiology textbooks call it as standardization. What actually this represents? This actually represents 1 millivolt of an electrical impulse is drawn as the wave of what size. So this always represents 1 millivolt. Now I can set it to draw a line of 1 large square for 1 millivolt, or I can set it to draw a line of 2 large squares for 1 millivolt, or maybe 4 large squares. I can set it. In a standard ECG, it is set 1 millivolt is set to draw a line of 2 large squares. 1 millivolt is set to draw a line of 2 large squares. From this understanding, we can calculate the amplitude or voltage of any waveform we want. Like for example, this is equal to 1 millivolt. So now tell me, R wave is more than 1 millivolt in voltage, or it is less than 1 millivolt? You can look at it, right? Just a gross look. Forget about precise calculation. This is equal to 1 millivolt. So now comparatively, R wave is more than 1 millivolt or less? It is more, right? P wave is less. Okay, right. We have understood. This is called as standardization. Now, in the x-axis, I am going to calculate the time. So now this time will depend on the paper speed, right? If I run the paper faster, the time taken for a waveform to form will be different, and if I run the paper slower, time taken for a waveform to be formed on the paper will be different, right? So now on a standard ECG, the paper speed is set at, what is the paper speed of the standard ECG? What is the paper speed of standard ECG? Can anybody tell me? ECG paper speed on standard ECG. Now what do I mean by standard ECG? Standard ECG is one where I am not tampering with the settings in the machine. It is working on the default settings. If I want, I can increase the paper speed, I can decrease the paper speed. So on the standard ECG, paper speed is 25 millimeter per second. 25 millimeters per second. So the paper moves 25 millimeters in 1 second. So in one of the classes, I was asking what is the standard paper speed, and everyone remembers 25, but this unit sometimes be confusing. So one of the students told that 25 meter per second. So imagine the scenario, right? The staff nurse presses the button of the ECG machine, and in 1 second, the paper is going to come out for 25 meters, if that is the paper speed, right? So in 2 or 3 seconds, the whole ECG room will be filled with paper. So literally you have to press the button and run away from the ECG room. No, it is not 25 meters per second. It is 25 millimeter per second. So when the paper speed is set at this, as you look into the ECG, remember ECG has these large squares, right? And within the large squares, there are small squares, right? So each large square comprises of 5 small squares horizontally, 5 small squares vertically. So this is comprising of 25 small squares, right? Each large square comprises of 25 small squares. So when the paper speed is set at 25 millimeter per second, in terms of horizontal distance, right? One small square is equal to 40 milliseconds. 40 milliseconds. 40 milliseconds. So with this understanding, right, can I say one large square? One large square horizontally contains how many small squares? It contains 5 small squares. So one large square is equal to 200 milliseconds. So from this, can we calculate the duration of any of the waveform on the ECG? Mohammad Huzaifa Delani, absolutely right. 0.04 seconds or 40 milliseconds, which is both same. So here now, can you calculate the duration of the QRS interval? Duration of QRS interval? How many it seems to be? This is one large square, right? Remember, small squares may not be clearly visible to you, but let me label. It is beginning here and ending here. So I can see 1, 2, 3 small squares. 3 small squares from the beginning of Q to the end of S wave. 3 small squares. So what is the QRS duration here? QRS here is 3 small square. And as we know, 1 small square is equal to 40 milliseconds. So that means here QRS is 40 into 3, 120 milliseconds, right? So this is how we can calculate the duration, okay, of any waveform, right? Let us say this waveform. Don't bother what is it. It is P wave. It is a ECG of atrial flutter. For now, don't bother. Let us say this is P wave. Okay. So from here to here, can I calculate the duration? How much it is going to be? So it is roughly, I can say 4 small square. So if it is 4 small square, 4 into 40 milliseconds, that is 160 milliseconds. So I can say this waveform, whatever it is taking 40 milliseconds of time on the ECG. Clear? Now, similarly, the default setting of the ECG voltage or standardization, right? We will call it as voltage standardization. Default, we're talking about voltage standardization, or the scale for voltage on standard ECG is 1 millivolt is equal to 10 small squares. 10 small squares, which is also equal to 1 large square is 5, so 2 large squares. 2 large squares. So what does that mean? 1 small square is equal to what voltage? When I look at height, 1 small square is equal to what voltage? 1 small square equal to 1 by 10 millivolts, that is 0.1 millivolt, right? 0.1 millivolt. So with this understanding, we can calculate the amplitude or voltage of any of the waves on the ECG. Any of the waves on the ECG. Very good, Rohina. So now I want you to calculate and tell me what is the amplitude or voltage of this R wave. Voltage of this R wave, right? So for the easy visibility, let me label it. It is ending here, beginning here. So what is the voltage of this? 1 large square, 2 large square, 3 large squares, right? I can see 3 large square. So as we know, 1 large square is 5 small squares. So total I have 15 small squares. So what is the voltage of this R wave or the amplitude of this R waves? 15 into 0.1. So that will become 1.5 millivolt. 1.5 millivolt. So the voltage of this R wave is 1.5 millivolt. Earlier you only had told me it appears to be more than 1 millivolt, right? It appears to be more than 1. Now we calculated it precisely to be 1.5 millivolt, right? Similarly, we can calculate the voltage of any waveform we want, right? For example, if I want to calculate the voltage of this P wave, it appears to be 2 small squares to me. Not very clear, but it appears to be 2 small squares. So in that case, it becomes 0.2 millivolt. So this way we can calculate voltage as well as the duration of any wave or any interval, right? Just let us do one more exercise here. Let us calculate the PR interval here. What is PR interval? Remember, intervals always contain a wave. So it will begin with this P, right? And end with the beginning of QRS. So this blue line, right? This is my PR interval. So it appears to contain 4 small squares. So then what is the PR interval here? We're talking about interval, duration, right? 4 into 40, that is 160 milliseconds. So the PR interval here in this wave complex is 160 milliseconds. So this is how we calculate the time and the amplitude or voltage of any of the wave. Now with this backdrop, is it possible for us to calculate the heart rate? Well, that is also possible. So not just we can calculate the amplitude or duration of individual waveforms on a standard ECG, assuming that the paper speed is 25 millimeter per second, we can calculate the heart rate. Okay, so how do I calculate the heart rate? For calculation of the heart rate, there is a formula. So heart rate is equal to, remember it is for the standard paper speed. If you change the paper speed, the formula will always change. Heart rate is equal to number of large squares, number of large squares between two consecutive R waves, and we are taking this number and we are dividing 300 by this number. This gives me the heart rate. Very quick calculation. If I want a more precise calculation, I can also follow one more formula, which is nothing but 1500, because remember, one large square contains how many small squares? 5. So now instead of using large squares, I want to use small squares, then I have to change that to 1500 divided by number of small squares between two consecutive R waves, number of small squares between two consecutive R waves. That gives me my more accurate heart rate. Okay, so with that understanding, right, let us say if we can calculate the heart rate. I will give you an ECG. I want you to calculate the heart rate and tell me. Okay, so it is not taking. Let's just give me a second. Number of small squares between two sequential or consecutive R waves. So I'm giving you an ECG and I want you to calculate the heart rate here. Forget about that 1500 and small squares, because I'm very sure you can't see the number of small squares, but you can see the number of large squares, right? So this is an R wave, this is an R wave. So you have to calculate the number of large squares between the R waves. So how many large squares I can see? 1, 2, 3, 3.5, right? 3.5. It is appearing to be 3.5. So quickly tell me, heart rate is more than 100 or less than 100? Quick question. I've given you the formula, and remember here I have 3.5 large squares between two consecutive R waves. What is the formula? If I'm using large squares, 300 divided by number of large squares. So will it be more than 100 or less than 100? Nishanti, we are going to begin it soon. As the Bailey series completes a major chunk of the syllabus, we will start with the Harrison again. Yes, see, remember, 300 divided by 3 will give you the rate of 100. Anything more than 3 will give you a rate of less than 100. So can I quickly say that this ECG does not have tachycardia? Because to call it as tachycardia, heart rate should be more than 100. The moment I see more than 3 large squares, I know that heart rate is less than 100. So it is not tachycardia. Clear? Okay. And what is the bradycardia? We will call it as bradycardia when the heart rate is less than 60, right? So can I quickly recognize whether a patient is having bradycardia when I look at the ECG? If I divide 300 by what number, I get heart rate of less than 60. If I divide 300 by 5, right, what is going to be my number? 60. So if the large space between two R waves is anything more than 5, what is the heart rate I'm going to get? Less than 60. So that means I have bradycardia, right? That means I have bradycardia. So this way we can easily identify whether patient has got tachycardia or bradycardia. If there are only, let us say, 2 large squares, then 300 divided by 2, it will become 150. I know quickly that it is tachycardia. So to recognize whether a patient is in tachycardia or bradycardia, we don't have to do mathematical calculations. A quick look, right? So if it is taking less than 3 large squares, I have tachycardia. If it is taking more than 5 large squares, I have bradycardia. Clear? Okay. Same, if you want more accurate heart rate reading, you can calculate the number of small squares and then 1500 divided by the number of small squares between R wave, you get more accurate number. Okay. Now, I'll give you one more ECG and I want you to calculate the heart rate here. Muhammad Huzaifa, absolutely, very good. What is the heart rate here? Follow the principle that we followed and will I get the heart rate? See, if I calculate heart rate here, it appears to be like 2.5 small squares, right? Here also it is 2.5 small squares. So let us calculate heart rate according to the formulas that we know here. So 300 divided by 2.5. And if I calculate here, how many? 1, 2, 3 plus, little more than 3, right? So let us say it is 3.2 or something. So 300 divided by 3.2. So will I get the same heart rate if I use these two sequential R waves or these two? No, because here the RR interval is irregular. So whatever formula that we learned is applicable only when the RR interval is regular. In this case, the RR interval was regular, right? It is not changing. Same numbers here, same numbers here, same numbers here. So these formulas are applicable only when we have a constant RR interval. If the RR interval is varying, these numbers are not applicable. So if I have constant RR interval, then these formulas we will use. If the RR interval is varying, what formulas we can use? So if there is varying RR interval, there are various methods, but a quick method that will help also in the exam and in your Viva OSCE is a very simple method. Okay, so to understand that method, I have a question. How much time it takes for the ECG to record? We have understood basic standards, right? Paper speed is set at 25 millimeter per second. And any waveform, its amplitude, 1 millivolt is represented as 2 large squares or 10 small squares, right? And which I can see here as the representation, right? So whether paper standardization of voltage is altered or not, I can see by comparing it to this standardization mark. Okay. Now, for what duration I should record the ECG? The standard ECG is recorded for 10 seconds, not like 2 minutes, 3 minutes. Of course, operational things like setting the leads, then pressing the button, and then getting the printout, it all takes time. But once all this is set and the button is pressed, the machine records the electrical activity of the heart for 10 seconds. So whenever you look at the ECG, at the bottom of the ECG, you get one strip, which is usually called as rhythm strip. This strip is added in addition to the standard 12 leads. One of the lead, usually lead 2 or lead V1, is put at the bottom. This is very, very important because to analyze the rhythm, when I look at the other leads, right, let us say I'm looking at lead 2. How many wave complexes I can see in lead 2? 1, 2, 3, 4, right? Depending on the heart rate, maybe a little more or a little less. But let us say there is a patient where every 10th beat of the ventricle is missed. So I will have all these 4 appearing, but the 10th QRS is missing. So I cannot detect it if I'm only recording it for the 4 waves, right? Like, let us say that every second over, right, Bumrah takes a wicket. But if I see only 3 balls, I will not see that wicket, right? So I need to see it continuously. So to see it continuously, at least one lead we record continuously, which is given at the bottom. It is usually lead 2 or V1 because P waves are better seen in those leads. Okay. Now this recording always represents 10 seconds of recording. This represents 10 seconds of recording. Now with this understanding, tell me, can I calculate the heart rate? Can I calculate the heart rate? Well, very simple. This is 10 seconds of recording. So I will measure the number of R waves, right? Whatever is the number, let us say in this case, it is 17. I'm just giving you a hypothetical number. Let us say it is 17. 17 beats in 10 seconds. Now I want to know how many beats in 60 seconds. So what should I do? I have to just multiply it with 6. That gives me the heart rate. So whenever there is varying RR interval, the simplest and easiest method which helps you to quickly calculate the heart rate is number of R waves on rhythm strip and multiply that with into 6, right? That is going to be my heart rate. This is based on the assumption or the accepted standard that ECG is recorded for 10 seconds at a paper speed of 25 millimeter per second. So I'm always getting the 10 seconds of cardiac activity trapped in my rhythm strip. I just multiply it with 6 to get the heart rate. Okay. There are other methods where you can calculate some number of large boxes. Then we will see how many R waves are there in that. All that mess is not required. It's more easier without giving much mathematical work to bring. Just measure the number of R waves, multiply it with 6, we get the heart rate. So whatever we have learned so far, right, let us put into some action. So I'll give you a waveform. I want you to calculate the duration of the P wave, amplitude of the P wave, R wave amplitude, and QRS interval. Like here I have a P wave, right? Is it visible to you? Rohina Rashid, very good, very good. This is the P wave, right? So as I see 1, 2, little more than 2, for simplicity, let me presume it as 2 small squares, right? So if P wave amplitude is 2 small squares, let us also see the duration. And duration also appears to be 2 small squares. So if duration is 2 small squares, what is its duration in terms of, right? So P here is equal to 2 small squares in terms of duration. So what is the P wave duration here? 1 small square is equal to 40 milliseconds. So 40 into 2, it becomes P here is equal to 80 milliseconds. Okay. Now similarly, I have to calculate the amplitude or voltage. So that also appears to be 2 small squares. It is little more than 2 small square. For simplicity, we will count it as 2. I'm giving you the numbers only because on the screen, I'm sure you're not able to see it. When you get the PDF, you will be able to see it. So amplitude of P wave is, so P here is again equal to 2 small squares in terms of height. So what is the P wave amplitude here? Yes. So P here is equal to 0.2 millivolts. So 1 small square is 0.1 millivolt. Okay. So similarly, we will calculate the R wave amplitude, right? So I have to calculate the R wave amplitude. So as I see, I have 1 large square here, 2 large square, 3 large squares, plus 1, 2, 3. Right, almost 4. Let us say 4 small squares plus 3 large squares. So 3 large squares is equal to 15 small squares plus 4 small squares. So total I have 19 small squares. So what is the R wave amplitude here? So here R is equal to 19 small squares. So what is the amplitude here or the voltage of R wave? Yes. 1 small square in terms of voltage is 0.1. So 19 into 0.1 is 1.9 millivolts. 1.9 millivolts. Okay. Now we will also calculate the QRS duration, and if possible, we'll also look at the QT interval. The QRS duration begins with the beginning of the Q wave here, right? Ends with the end of S wave here. Okay, let me draw more fine lines here and here. So how many small squares I have? This is 1, 2, little more than 2. Let us say 2.5. Okay. Let us say 2.5. So if QRS in terms of duration is 2.5 small squares, 2.5 small squares in this case, then what will be the QRS interval? 1 small square is 40 milliseconds, right? So 40 into 2.5, that is 40 into 2 is 80 plus another half is 20. So I have 100 milliseconds. 100 milliseconds. So this way we will be able to calculate any of the interval and waveforms amplitude, voltage as well as the duration. So tomorrow if you get an ECG, will you be able to, if I ask you, right, how much time atria is taking to get depolarized, you will be able to tell me by looking at the P wave duration. If I ask you how much time the ventricle is taking to get depolarized, you will be able to tell me that by looking at the QRS interval. If I ask you tell me how much time the ventricle is taking to get depolarized and then repolarized again, then you can tell me by calculating the QT interval. Right? If I also ask you to correct it for the heart rate, you should be able to tell as we go forward. If I ask you how much of voltage was required for me to cause the contraction of the ventricle, you can measure the amplitude of the QRS complexes and you should be able to tell me. Similarly, what was the voltage of the wave that caused the atrial contraction? You will be able to measure the amplitude of the P wave and you should be able to tell it, right? So I think we have got the basics right today. Before moving, just a quick recap. So amplitude of any waveform on the ECG is equal to number of small squares in height into 0.1, because one small square is 0.1 millivolt. Similarly, duration of any waveform is number of small squares into 40, because one small square is 40 milliseconds, right? That's how we can calculate. So I'm leaving behind some exercises on the ECG for you to calculate the intervals and the amplitudes. We will complete that for today. From the next class, we will start understanding the lead placement, because the waveforms, when you look at any ECG, right, they all don't look same, right? AVR looks different from V1, right? Lead 2 looks different from V5. So why we get these different morphologies? It's all because of the placement of the leads. So in the next session, you'll understand placement of leads and then how to recognize the axis of the waveforms, right? So with that, we'll slowly start building up. We will also study about the individual waveforms like P wave, their abnormalities, and then what conditions we see. And as we go forward, we'll start bringing the NEET PG questions. So that's all I had for today. I'll see you in the next session, which is scheduled on 27, where we will be discussing the lead placements, how to recognize whether the lead placement is appropriate or any misplacement has happened, and then how to calculate the axis, electrical axis of the heart. Okay, and then we will start talking about the individual waveforms. What we have learned today, we have learned what is segment, what is interval, how to calculate the amplitude of a waveform, how to calculate the duration of a waveform, and how to calculate the intervals. So with that, I'm signing off today. I'll see you in the next session. Till then, have a good day. Thank you, everyone. Thank you.